Ladies and gentlemen, welcome to the Policies and Strategies to Improve Lung Cancer Screening Rates. Before we begin, as a reminder, at the bottom of your screen, there are multiple application widgets you can use. All of the boxes are resizable and movable, so feel free to move them around to get the most out of your desktop space. For the best viewing experience, we recommend using a wired internet connection and closing any programs or browser sessions running in background that could cause issues. For the best audio quality, please make sure your computer speakers or headsets are turned on and the volume is up so you can hear the presenters. And make sure the media player on your screen is enabled. If you have any technical difficulties during the webcast, please let us know via the Q&A box. If you have any questions during the webcast, you can submit them through the Q&A box. This webcast is being recorded and will be available tomorrow and can be accessed using the same link you used to register. And now we'll begin the webcast, and I'll turn it over to Erica Swart, National Assistant Vice President of Advocacy for the American Lung Association. Please go ahead, Madam.
Thank you so much, and welcome to everyone for joining us today. We're glad to have you with us. As the operator said, my name is Erica Swart, and I'm the National Assistant Vice President for Advocacy, and I'm pleased to join you today to moderate this webinar. Just a little bit of background before I introduce our speakers. As I think everyone on this call knows, that lung cancer is the leading cancer killer of both men and women in the U.S. And within the last decade, a new low-dose CT screening has risen to the top of some of those important preventive screening that we can do in the U.S. Because it has been found to reduce lung cancer rates, death rates for those who are at high risk for lung cancer by up to 20%. Unfortunately, screening rates really vary dramatically by state, with a 4.2% overall national screening rate for people at a high risk, and then that ranges at the bottom for 0.5% of people at high risk being screened in Nevada, with 12.3% being screened in Massachusetts. And so we're going to talk a little bit more about these issues today, and I'm very pleased to be joined by a wonderful group of speakers. Let me introduce them all, and then I will turn it over to them to take us from there. Hannah Green is the National Director of Health Policy for the American Lung Association. She oversees the Lung Association's policy work on access to care for lung disease patients, particularly in Medicaid and state marketplaces, and is also the Lung Association's expert on lung cancer, asthma, and other health and healthcare systems policies. Linda Dowling with the Rush University Medical Center made a mid-career change from marketing to nursing following her mother's diagnosis of lung cancer. After obtaining her BSN, Linda focused her career on outpatient oncology and thoracic nurse navigation. She joined Rush in 2015 and helped implement and currently manages the Rush Lung Cancer Screening Program. As part of her dedication to the growing and evolving field of lung cancer screening, Linda helps form the Chicagoland/Northwest Indiana Lung Screening Consortium to help those working in screening network collaborate and grow their programs. She holds both oncology nursing and tobacco treatment specialist certifications. And finally, Claire Brockbank is a founder of Segway Consulting, a healthcare strategy and business development firm. She's worked for the U.S. Congress and state governments with national and insurance carriers and health plans, and as an executive with an employer coalition and several healthcare startups. She has a long history of working with the Centers for Disease Control and Prevention and multiple state governments to identify and analyze ways to promote mutually beneficial health and wellness strategies between public health and private carriers. She's worked on tobacco coverage issues for the last 15 years. Claire received an MS in Health Policy and Management from Harvard University and her undergraduate degree from Stanford University. It's now my pleasure to turn our webinar over to Hannah Green with the Lung Association.
Thanks so much, Erica, and thank you everyone for joining us today.
The Lung Association has a number of different initiatives that are focused on increasing screening rates among those at high risk. And one of the policy priorities that we've really focused on has been working to ensure that all patients at high risk have quality and affordable health coverage that provides access to screening without any financial or administrative barriers. So what I'm going to talk about today is sort of the lay of the land with where coverage for lung cancer screening is right now. Talk about some of the work that the Lung Association has done to identify gaps in coverage. And then finally, I'm going to talk about some breaking news from last week from the U.S. Preventive Services Task Force that has really important implications for coverage of lung cancer screening moving forward. So looking at where things are right now, the Affordable Care Act required most private insurance plans to cover any preventive services with an A or a B grade from the U.S. Preventive Services Task Force at no cost to patients. And in December of 2013, USPSTF gave lung cancer screening for individuals at high risk for lung cancer a B grade. And it defined the high-risk population as individuals 55 to 80 years of age with a smoking history of at least 30 pack years and who currently smoke or have quit within the last 15 years. Again, there's a little asterisk there. We're going to talk more about some of the changes to that criteria later in my presentation. In 2015, Medicare began covering lung cancer screening for a very similar high-risk population with a slightly different age range, 55 to 77 years of age, but similar high-risk criteria. And then when it comes to Medicaid, the Affordable Care Act also required states to cover those preventive services with an A or B grade from USPSTF for individuals who enrolled in Medicaid through the ACA's Medicaid Expansion for individuals who have incomes up to 138% of the federal poverty level. So as a result, in the 37 states and the District of Columbia that have chosen to expand their Medicaid programs under the ACA, adults in the expansion population who meet the USPSTF high-risk profile also should have coverage for lung cancer screening. However, those requirements do not extend to the standard Medicaid population. Medicaid is a joint partnership between the federal and state governments. The states have a lot of flexibility in terms of the benefits that they cover, and so until the Lung Association started to take a look at this issue a couple of years ago, there really wasn't a lot of public information about what different Medicaid programs were and were not covering for their standard Medicaid population. So through the State Lung Cancer Screening Coverage Project that the Lung Association launched last year, we began assessing current coverage of lung cancer screening in state Medicaid fee-for-service programs for that standard Medicaid population. We first collected this data in December of 2018, and we've updated that data, which we're sharing with you today, collected new data from December of 2019 through February of this year. And we sent a short survey to Medicaid staff in all 50 states and D.C. asking for details and documentation of their lung cancer screening coverage policy, what eligibility criteria they were using, whether they had any prior authorization requirements for screening, and for the first time this year, we asked if they had any cost-sharing requirements as well. So this here shows our results and what we found this year. 37 Medicaid fee-for-service programs covering lung cancer screening, 10 programs not covering screening, and 3 states that didn't have information available about their coverage policies. Tennessee is the state in white there. Tennessee covers all of their Medicaid enrollees through managed care, private managed care plans, and so they don't have a fee-for-service program that we could do this analysis for. Since last year, when we first collected this data, we've seen some really important progress in both Rhode Island and Kansas, now covering screening. Kansas just implemented this coverage on July 1st of this month, so that was really exciting. We've also seen improvements in the data that we were able to collect, and far fewer states with no data available, which is a great sign of progress and transparency about coverage, which is obviously important to make sure that patients, know what is covered and are able to get screened if they're at risk. So for the 37 states that did cover screening, I said we looked at a couple of other questions as well. We found that 21 of those states followed the USPSTF criteria that I mentioned on one of the earlier slides. 4 states followed the Medicare criteria, and 12 states followed other criteria. This could mean that they followed criteria that was slightly different from USPSTF, or that they followed criteria. They didn't have a sort of written coverage policy over who met the high-risk criteria to be screened. Establishing clear eligibility criteria for lung cancer screening is important to ensure that only those who are at high risk for lung cancer obtain screening. Screening people who do not meet the high-risk criteria puts people at risk for false positives and unnecessary invasive procedures. So next, we look at whether states required prior authorization for screening and found that 15 states did so. This means that providers have to get prior approval from the Medicaid program before performing the screening in order for it to be covered. And research has shown that prior authorization requirements can delay patients' access to care and even lead some patients to abandon treatment, or in this case, not follow through on their screening. This is different than the shared decision-making visit that's required under Medicaid before screening is covered. So just wanted to make sure that that distinction was clear. And so finally, as I mentioned, for the first time this year, we also asked a question about cost sharing and found that 4 states charged copays for their screening. Research has shown that even relatively low levels of cost sharing for low-income populations will limit their use of necessary health care services. And so for a low-income population like the Medicaid population, a copay as low as $1 or $5 really could be the difference between them, following through it and getting a screening, or deciding that they can't afford it and not getting that screening. So just a couple of key points to wrap up this section on Medicaid. As I mentioned, we've seen some great progress with Kansas and Rhode Island beginning to cover screening and more data and information about screening coverage available. But gaps still certainly exist in lung cancer screening for the Medicaid population, and the Lung Association urges all state Medicaid programs to cover lung cancer screening based on evidence-based guidelines across all fee-for-service and managed care plans, and to remove any financial or administrative barriers that could limit access to this life-saving service. So next, I want to talk a little bit about Medicaid expansion. And as I mentioned earlier, under the Affordable Care Act, states that have expanded their Medicaid programs are required to cover lung cancer screening for people enrolled through Medicaid expansion. And as you can see from this map from the Kaiser Family Foundation, 38 states, including DC, have adopted Medicaid expansion. 2 of those states recently passed ballot measures to expand their Medicaid programs. Nebraska's was passed in November of 2018 and is scheduled to be implemented this fall. And Oklahoma's passed just a few weeks ago on June 30th and is scheduled to be implemented by July 1st of next year. But in the remaining states that have not expanded their Medicaid programs yet, there are, a number of individuals who would qualify for lung cancer screening if their states expanded their program, but at the moment are likely uninsured or falling into the coverage gap between and not able to get help paying for coverage through the Affordable Care Act marketplaces. Just to give a kind of a better sense of those numbers, so this is for individuals overall, not just those who meet the high-risk high-risk criteria, for lung cancer screening. But there are 2.3 million individuals in the coverage gap, meaning that they have individuals above Medicaid eligibility limits in their states, but below the poverty level where they could qualify for that financial help to receive coverage. And this number is expected to grow fairly significantly as a result of COVID-19. An additional 1.9 million individuals are expected to fall into the coverage gap this year due to a loss of employer-sponsored insurance as a result of COVID-19. Research has really shown a lot of benefits for patients both at risk and with lung cancer as a result of Medicaid expansion. I highlighted one of them here, Medicaid expansion. Research has shown an association between Medicaid expansion and early-stage cancer diagnosis when cancer is often more treatable. That's certainly the case with lung cancer. We have a new fact sheet on our website about Medicaid expansion and the benefits for individuals with or at risk for lung cancer, and I'll share a link to that at the end of the presentation. In terms of gaps in private insurance coverage, as I said, most private insurance plans
are required to cover screening without cost sharing, but there are still a number of issues that we hear from patients that they're facing. One is the growth in plans that do not have to meet the ACA's coverage requirements, growth in short-term plans or other skimpy plans that don't have to cover preventive services. These plans have really grown as a result of a number of regulations that have come out of the federal government over the past couple of years. Short-term plans, for example, a recent report found that they've increased 27% between 2018 and 2019. And so certainly the growth in plans that don't have to meet these coverage requirements is a concern for ensuring patients have coverage for screening. Another issue that we hear about is out-of-network coverage issues. Patients should have coverage without cost sharing in most private plans if they go to an in-network provider, but sometimes patients unknowingly go to an out-of-network provider and end up with a large bill for screening that they weren't expecting. And I think there's finally just more that we could be doing across the board to make sure that plans are, following the law and enforcing that we're enforcing the coverage requirements that are on the books right now. And then finally, obviously, Medicaid expansion in the remaining states that haven't expanded would do a lot to improve coverage for lung cancer screening. But we still have millions of patients who are uninsured. A number of states, other healthcare stakeholders do run screening programs to provide free or low-cost screening to people without insurance. But obviously, there's still a lot more that we can be doing to reach that population. So as I previewed at the beginning, we had some really exciting news last week when the USPSTF released a new draft recommendation on lung cancer screening. Lung cancer screening still has a B grade, which is great news, but they've expanded the high-risk population to include individuals 50 to 80 years old instead of 55 to 80 with a 20-year PAC history, that's down from 30 PAC years currently, who currently smoke or have quit within the past 15 years, which is what the requirement is right now. This is really exciting news that would nearly double the number of individuals who meet the high-risk criteria, and as I outlined earlier, has important implications for coverage. In terms of next steps, comments on the draft recommendation are due to USPSTF by August 3rd. The Lung Association is certainly planning to submit comments on that recommendation. Once the comment period is over, USPSTF will issue a final recommendation, and then private plans and Medicaid expansion, both of which rely on the USPSTF recommendations, will be required to comply with those new criteria within a year. It is important to note that Medicare and many of the state Medicaid policies that we looked at for the standard Medicaid population won't change automatically, and so we'll have a lot more work to be done to make sure that those high-risk definitions also expand to make sure everyone who's truly in that high-risk group has the coverage that they need to receive screening. So if you're interested in learning more about these issues, we have resources online at lung.org/lung-cancer-coverage. We have the coverage map that I showed earlier about our Medicaid assessment, along with state-specific information about eligibility criteria, cost sharing, and prior authorization requirements. We have a number of educational materials that we put together last year that can be useful in learning more about coverage and educating decision makers about the need for coverage of lung cancer screening, a portal for patient stories, and just a bunch of other resources for public health and lung health professionals, state and local coalitions, and healthcare providers to use in their work on screening and coverage. So thank you so much, and with that, I will turn it back to Erica.
Thank you, Hannah, and I am very excited to now turn things over to Linda. So Linda, do you want to take us from here?
Absolutely. I'm thrilled to be here today, and before I jump into my presentation, I do have to state that I recognize that all lung cancer screening programs are very unique to their own facility, but it's my hope today that with some of the comments that I've made and ideas I've shared, that there might be something that you can take back to your facilities. So before I get into further content, I'd like to share with you a little bit about Rush. Rush is a major academic medical institution, and it lies and sits on the west side of Chicago. It's comprised of 3 hospitals: Rush Hospital, which is the white building that you see in the left image, as well as a hospital in Oak Park and also in Aurora, Illinois. The information, the illustration on the right-hand side is very telling in terms of our diverse patient population and communities that we serve. If you look to the far right-hand side, you'll see that the life expectancy in the loop, which is essentially where the beautiful skyline of the city sits, is 85 years of age. Traveling just a few miles west, though, it drops down by about 15 years in the West Garfield and East Garfield Park area, which is where Rush is located. So we do serve a very, very diverse community. We launched our program in 2015, and when we did that, we had incredibly strong institutional support. And that support was mainly from our thoracic surgery team, as well as our medical and radiation oncologists, as well as a dedicated thoracic radiologist and our pulmonary team. The program was built and designed to be decentralized in nature, meaning that our providers, mainly primary care providers, would order the exam, patients will schedule it on their own, and then nurses, myself and a colleague, would review patient eligibility. We'd meet with patients after their scans, navigate any positive findings to the appropriate providers. At the time we established the program, we didn't have a tobacco cessation program in place. We knew that we needed to address that given CMS guidelines. So let me share with you some of our successes. I do think our core team was so imperative to our forming and getting this program off the ground. And that core team essentially was a subset. I worked extremely closely with our radiologists and also with our thoracic surgery team. I knew that I could get patients to them very quickly if need be. We also crafted a very robust clinical reminder. It essentially had all of the elements required by CMS. It was triggered based on age as well as tobacco history. We also had very, very few issues with reimbursement, and I think that's for a couple of reasons. Medicaid patients within the state of Illinois, exams are covered, so that's not an issue there. Additionally, the secondary step of reviewing patients for eligibility and also looking at the diagnosis codes has really helped us. Also, in 2017, we initiated reminder letters directly generated from our EMR. Right now, our retention sits at about 50-60%, although I suspect it's grown. And that's really helped us. And finally, early last year in 2019, we implemented an EMR referral for tobacco cessation. That was created after we actually attempted to deliver, but were not successful with delivering on-site classes and also a work queue of tobacco cessation referrals. The EMR consists of 4 elements. There's a referral to a quit line, an online digital coaching system we use, referral to tobacco cessation classes, albeit at our suburban locations, as well as a referral to a certified tobacco treatment specialist. That being said, we definitely had challenges for our program. We did have slow adoption by providers, and the adoption was driven by a number of factors, and I'm certain many of you have contended with them. And they include concern over the high false positive rate that was noted with the NLST, also concern about invasive procedures and patient anxiety. Also, at the time of our implementation, we didn't have a primary care champion. That changed a few years ago, and since then, I've actually seen our volumes grow, and that's been a huge help to our program overall. Tobacco history has been an ongoing burden and challenge for us. It's incomplete, it's inaccurate, frequently altered, and patients are either omitted or dropped from the screening program if the tobacco history is altered. As I mentioned, we took great pride in developing this clinical reminder, but it's driven on tobacco history. So if it's altered, it may not be triggered, or we also have another alternative ordering process, and most often our providers don't use the robust reminder. And finally, like many of you on the line, we struggled with data management, not only with the tobacco history, but registry submission, generating program metrics, as well as patient management. We do use a third-party system now for our patient and data management, and it's improved, but we still grapple with that. So this is our program at the end of 2019, and what you see is that we had screened about 1,200 patients. We had a 3.6% lung cancer incidence rate, had detected 41 lung cancers, 60% of which were early stage, as well as 12 other incidental cancers. Demographically, the patients that we screen mirror our overall patient population and pretty much equally split between male and female, current and former smokers, with an average age of 65 years of age. And I'd like to pause here because of what I will say is at the end of 2019 going into 2020, things felt really good. The program volumes were increasing. We felt respected and established. There was a lot of buzz about the Nelson trial, and that was further validating the importance of screening with our primary care providers. I had also begun working locally with other screening centers, and we were starting to collaborate and work on some other meetings. So things felt really good. And then everything, like everything else in our world, kind of ground to a halt in March 2020. We began conversations early March on when we were going to close the program. We closed it officially March 16th. Our initial plan was to be closed through May 11th. We ended up extending it to June 1st. We had about 45 exams scheduled, which we canceled. We also held back our reminder letters because we didn't want to confuse our screening patients. Those were sent after we had established a reopening date. So on the next few slides, what I want to share with you is kind of how we approached it. And again, there's no science behind this. We did what was right for our institution, and we used whatever resources we had available for us. So how did we reopen the program? What we ended up doing was following the lead from our breast screening team. Right around the time that we were looking at that, there was a CHEST report that was published for the management of lung nodules and screening, and that gave actually very good guidance. And if you haven't seen that, I would encourage you to review that because it may help you with reopening your programs if they are still closed. Collectively as a team, we decided due to social distancing, we weren't going to meet with patients anymore after their scans. And although we officially opened on June 1st, there were a handful of patients that had positive findings, and so we screened those mid-late May. Also, some important considerations is that you don't necessarily want to screen patients who have been infected with COVID-19 too soon because they might need another screening or low-dose CT. So that's essentially somewhat defeating the purpose of the exam. I think it's also important for allowing time for patients to feel comfortable to return to your facilities and also maintain social distancing protocols. While our techs are great with that, our waiting areas are very cramped at Rush, so that presents a definite challenge. Other tactics that might be considered are extending hours to evenings or weekends and also using off-site locations if available. Also, as I noted, within Rush, our patients are incredibly complex. So right now, our primary care providers, and they're the ones that are mainly ordering the screening exams, are being burdened by the impact of patients delaying their own care for about 2.5 months. So their focus is elsewhere and not necessarily on screening. We also worked with our marketing department on messaging indicating that it was safe to resume cancer screenings. And off to the right, what you see is just some of the content And again, the message was much broader regarding returning to all cancer screenings. And finally, I think we all need to be fluid and flexible and anticipate that we might need to close in the future due to the pandemic. So looking ahead, I think one of the biggest questions that we all have is we don't know what the impact of COVID-19 has with our lung cancer screening, those who have been infected with it. And that's going to be a story that's going to play out over time. But I do think that there are things that we can look forward to in the future. And some important considerations are telemedicine. Obviously, that has been a huge success during the pandemic. So the question that I have is, how can we best implement it for lung cancer screening and also tobacco cessation? Secondly, tobacco history. That has truly, in my mind, been the Achilles heel for lung cancer screening. And I think we need to figure out ways to collectively, as screening centers and as a collaborative group, including EMRs, to figure out how to sort that out and make it accurate and easy to document. Likewise, I think shared decision-making has been the Achilles heel for providers. So are there ways that we can deliver this more expeditiously and easily? Also, I would say that collaboration with other programs is important. We have so much room to grow overall with screening, and yes, healthcare is incredibly competitive, but I think we have much to gain by sharing with each other. And I also would like to extend that also to the associations, the Lung Association, GO2, the American Cancer Society, and the ACR. I have established a relationship with them, and they all have vested interest in lung cancer screening. So I think it's important to tell them what you know and what you see. And finally, we have to see what the impact will be of the new USPSTF guidelines. And with that, I'd like to thank you for your time and your engagement. And now I will turn the floor over to Claire.
Thank you so much, Linda. Can everybody hear me? Okay,
yes.
Yeah. Great. So we're going to take a little bit of a shift here and talk about some of the things that we've heard from both Linda and Hannah. Are quality measures a way to maybe address some of those shortfalls? So we're going to talk about quality measures and how they might play out with respect to lung cancer. The reason that we're raising the issue of quality measures is, this is a very old saying, but what gets measured gets managed. And so we've seen some shortfalls in the discussion this afternoon. So what I'm going to do is take a few minutes to provide some rationale for why you might want to think about a quality measure for lung cancer screening, for which there's not one right now, and then provide some context for quality measures as a whole. So a little bit of a quality measures 101, and then similar to what Linda did, bring it back to some issues specific to lung cancer. So with that, we already heard this morning about the very low uptake among the eligible population. We know that eligible population is likely to grow if the new proposed standards are put into place. So, and we also know that from Linda, that there's real concern sometimes about over-screening and the complications that come with that. So the goal of a measure would be, can we use a quality measure to drive higher screening rates among the eligible population without increasing the rate among the non-eligible? So that's our goal. That's our holy grail, if you will. So with that, let's step back and say, what do we know about quality measures and how might lung cancer screening fit into those? So I'm going to talk about them from the perspective of the stewards of the measures, who uses the measures, what kind of data they're collecting, and what the goals are of different measures to see if we can find a fit there. So measure stewards. These are the people who develop measures, babysit them, pay attention to them, refine them, etc. And there's really 4 primary entities. The big one is NCQA. And they measure The two measures that you may have heard of are the HEDIS data set and the CAHPS Consumer Assessment of Healthcare Providers and Systems Survey. NCQA is an independent, it's a nonprofit, and it really exists to sort of administer evidence-based standards. They accredit hospitals, they accredit health plans, they accredit medical groups, so it's a very broad swath that they cut. The next one is National Quality Forum. It's also a nonprofit group. It's a membership group, and they really focus on patient protections and quality by way of measures, if you will. They use a very multi-step process to create their measures, and interestingly, they include some of the other players we'll talk about today, which is NCQA. They include Centers for Medicare and Medicaid Services, and a number of others. The next two are federal agencies. They're both part of the Department of Health and Human Services. AHRQ is the lead agency charged with improving the safety and quality of America's healthcare system. Broad mission. And it really works on developing knowledge and tools that will drive its mission forward. HRSA, it is the primary agency really focusing on serving our vulnerable populations. So those are people who are geographically isolated, economically or medically vulnerable. So they're a little bit more of a focused thing, but they also look at measures as a way to do it. So those are the four likely sources of a measure, if you will. The next we go to are measure users. So these are entities that don't tend to create new measures so much as to vet and endorse measures and gain traction in using the measures. So these are an important thing for the lung cancer screening community to think about. Who do they want using the measure? And that helps point to who do you want to do the measure. So by far, among commercial insurance companies and self-funded employers, so we heard today that while it's covered by many commercial insurance companies because of its B rating, the uptake is small. Those entities use HEDIS and CAHPS data, so that's NCQA. That's really the dominant data source that they look to. If you look at Medicare, huge consumer of metrics and data, they have a quality rating system that uses stars, et cetera, and they have 33 measures that they use. Those are a mix of each of those four that I talked about earlier, but NCQA dominates it with 20 out of the 33 measures. Likewise, Medicaid. They also have 33 measures in their adult core set. And so we focus on the adult set because, again, they have a pediatric core set, not likely to be applicable for this population. And again, NCQA really tends to dominate. So the other thing to think about as we look at who's using it and who creates the measures is what are your data source options? We heard from Linda about some of the issues with data. There's surveys. Surveys are used for the CAHPS, which is part of the NCQA, the consumer survey. Most of you are probably familiar with BRFSS, the National Health Interview Survey, et cetera. And those, particularly BRFSS, does have for the first time a module that has questions pertaining to lung cancer screening. They launched that in 2018. Publicly available data will be available this year. National Health Interview Survey also has some lung cancer screenings and some things about smoking history, including PAC years, that really critical qualifying issue, quitting, counseling, et cetera. But they are the ones, they suffer from that very low response rate and reporting rate, which Hannah shared with you. So that's surveys. One of the other issues with surveys, of course, is that they can introduce bias. There's memory gaps. People often underreport smoking history because they're worried about coverage or their premiums going up if they report that they smoke. The second option is claims or encounter data. Just by the very nature of them, that is going to be a subset of the population. A, it's only those people who have coverage of some sort, and B, it's only the people of coverage of some sort and use the system. So what you get are the people who you could look and see who had screening, but you may or may not know anything more about it than that. And I'll go into a little more detail on that in a minute. And then you have medical records. And that can be an electronic health record extract, which Linda talked about. It can also be a manual review. And each of those has issues. I'm not going to repeat them because Linda did some covering of them, but let's talk about it in the context of what we're trying to achieve with a measure. So remember, these are our three data sources: surveys, claims, or medical records. So the question becomes, in a survey or in a quality metric, are you looking at process or outcome? So for lung cancer screening, the process would be, did a screening occur? And we know we can ask that question. We can get information on that question from claims data. We can get it from survey data. We can get it from medical records data. What it does not tell us is the outcome piece of it, which is, was the screening appropriate? Was follow-up provided as it should be, the referrals to tobacco cessation and some of the other things that we've heard about this morning. So for outcomes measure, you can do surveys, but again, you get limitations, right? You won't typically be able with lung cancer to be able to say, you might be able to ask, did they ask me both questions? Did I use tobacco and how much volume did I use? And on medical records, you'll get also some limitations in terms of the kind of information that you can get. And one of the issues specifically for lung cancer screening is that sometimes the notes around tobacco volume, sometimes those are fields and sometimes those are notes, which makes them very difficult to search. So if we're talking again about process versus outcomes, let's feed that into lung cancer screening particularly, which we've done a little bit already. So the big challenge with lung cancer screening is getting that denominator. And again, we've heard that this morning. Only a subset of the population is eligible, and it is a two-step process, not a one-step process. Whereas for many other screenings, colorectal cancer screening, it's really, for the most part, an age. There are some complications if you're at risk, but it's mostly a one-step demographic classification. There are concerns about overscreening. We know that if people don't meet the high-risk criteria, that puts them at risk for false positives and those unnecessary invasive procedures that Linda talked about as a barrier to some of the adoption rates in her at Rush. And there's no clear data source for identifying either the eligible population or for documenting screening that's specific to that eligible population. So claims aren't a clear data source, surveys aren't a clear data source, electronic health records aren't a clear data source. So even if you could get great compliance, there's not necessarily the one magic data source. Now, lest you get really discouraged, most issues have those kind of limitations. So I'm going to do a really quick review, just applying it to tobacco, which many of you are more familiar with. The CAP survey is where we get our quality measures for tobacco. And for that, we know that advising happened, but we don't know if the patient quit. So again, process versus outcome. We know that for the CAP survey, it is one of the most frequently non-reported measures because of insufficient sample size. And so it's a very spotty measure. We know if you went to process, you could get it from EHRs, which would give you a much better data source. But this measure was created before we thought about EHRs and meaningful use. So again, really thinking about where you want to get your data and how it's going to play out in the future, as Linda talked about, is important. And even from an outcomes perspective, we know that there's very little consistency around quit rates. So I only say that to not let people get discouraged, that there's never a perfect situation, but we do still know that what gets measured gets managed. So a couple of things. Since the signs really pointed to NC2A, let's talk just a little bit about how you might think about that. So with HEDIS, which uses administrative or claims data, it's a really rigorous process to get through. and that's legitimate. We don't want to have providers overwhelmed with measures to track. It's expensive, and it tends to create a lot of burnout. Positive on HEDIS is that it's the industry standard. The negative is it's a really rigorous, lengthy process that's going to have to address those challenges with denominators and data sources that I just mentioned. So if you can cross the hurdles, it's the place to go. TAPS is the other place to go, and the big issue there is you could address the denominator issue in the survey structure, but the downside is if we're trying to do this to drive more utilization of this very important screening, there's no real data that says that TAPS actually motivates providers to change their behavior, and that is really fundamentally what we want to see happen, right? So with that whirlwind trip through quality measures and options, I'm going to turn it back over to I think, Erica for question and answer.
Wonderful. Thank you so much, Claire. And before we switch over to Q&A, I do want to take a moment to thank the University of Texas MD Anderson Cancer Center for their support for this webcast today. And with that, we're going to go to questions. As the operator mentioned earlier, at the bottom of your screen here, there is an opportunity to type questions in, and we've already gotten a number of them. I'm going to go ahead and read the first one, and then we can go from there. So please do take a moment if you do have any questions to chat them into the Q&A box now. Linda, the first question is for you. What advice do you have with working with primary care providers to improve screening rates?
What I would say is I do think trying to find a primary care champion is really important and cannot be understated. And I think that there can be a lot of variability how you go about this within an institution. For us, it was just identifying a person who's available and works in a very large clinic. But I do know of other facilities that identified a primary care physician. They ended up having meetings over meals, et cetera, and obviously this has changed a little bit with what's going on right now. But I think people have to determine the best way to go about that based on the needs of their facility. And it might take some research, frankly, to find somebody who is interested in screening as well.
Thank you. I also want to just take a moment to remind everybody that all of our resources, including which states charge copays and which ones follow USPSTF recommendations, all of those materials and our map is available at lung.org/lung-cancer-coverage, and so all of you can access everything there. Hannah, let me ask you this one. You mentioned that since last year's data collection, 2 states have added coverage for lung cancer screening in the standard Medicaid fee-for-service program. Do you know what factored into those state decisions?
Yeah, I mean, I think, for every state, it's going to be a little bit different. In some cases, we've been able, our lung association staff has been really taken this issue on, and in Kansas just worked really closely with the Medicaid program to bring this issue to them and to explain why we thought it was important and kind of walk it through their process to get a new service covered. In some states there might be a lot of buy-in in the Medicaid office, and it really could be just, developing a relationship with them and helping to raise this issue to their attention. In other states, there might not be that buy-in, and you may need to think about other champions who could help you kind of push this forward. And so I really think it'll depend, a lot on state to state and sort of the dynamics of their Medicaid programs.
Wonderful. And I think one of the other issues is, of course, taking the opportunity to flag these for us. And I think that the fact that we are having a new USPSTF recommendation gives everyone a good opportunity to do that. I may throw this out, and maybe Claire, maybe Hannah, but how often are the USPSTF recommendations reviewed? And how can all of us factor into this input for the new process, including how we can make sure that these are being communicated once they're final early next year?
Yeah, I can start with that.
If you want to address how, I'll talk about how to maybe communicate to health plans. Does that work?
That would be perfect. So the recommendation was last finalized in December of 2013, as I said. About a little over 2 years ago, USPSTF started a process where they put out a draft research plan for updating the recommendation, asked for input on that. I think, once the comment period is over, like I said, it'll take them, a few more months to finalize the recommendation. And then, that's sort of the timeline for this project. I think it's really important that if you, have opinions on the draft recommendation that was released last week, the public comment period that's going on right now is a really great way to express those and share your support for the new recommendation or any concerns you have about the new recommendation. So, the Lung Association is certainly going to be submitting comments on that. You can just go to the United States Preventive Services Task Force website to weigh in there. And Claire, if you want to take it from there.
Sure. So under the Affordable Care Act, anything that has an A or B recommendation from USPSTF is required to be covered by most health plans. There's some exceptions, but most health plans. They have essentially a cycle of about a year to integrate those into their benefit designs. They don't always pay the closest of attention to what's happening with USPSTF modifications. So it's really important that you all as supporters of this, in addition to providing the kind of feedback and responding to the metrics that Hannah just talked about in terms of giving feedback to USPSTF, really thinking your communities about how to promote that to your employers and your health plans to make sure there's coverage. And then making sure that the people who come in to see you, if you're clinicians, I know we have quite a few hospitals and health systems on the line, that they know that these are supposed to be available to any insured individual without financial responsibility. So it's really a cycle of, one, getting the changes made, two, letting that essentially almost a year elapse to make sure that it's fully integrated into benefit designs and facilitating that by communicating actively with health plans in your community. And then three, making sure that the people who might be eligible for those screenings know to ask for them and know that if they get charged for it, to submit it back again for clearance. We see this with colon cancer screenings initially. It happened a lot where people got billed for services until the health plans got the kinks out.
Thank you both. We've gotten a couple questions about whether or not this will be available as a recorded webcast, and I'm pleased to say that within about 24 hours of this presentation, the very link that you used to log on for today will also be able to be used to listen to the webinar so that you can change it. Usually the system takes about 24 hours and it will be available then. Hannah, let me ask you this. What are some of the common policy barriers to lung cancer screening when it is covered?
Sure. So I think the two ones that we've seen most often are our prior authorization, which I talked a little bit about. 15 states, had that in their Medicaid programs. And certainly on the private insurance side, that's a requirement we can see across a number of different healthcare services, screening certainly being one of them. The patients have to go through this process, some kind of prior authorization process before something will be covered. The other one that we talk a lot about is cost sharing. Luckily, because of the Affordable Care Act requirements for most private insurance plans and Medicaid expansion, when a preventive service like lung cancer screening has that has that A or B grade, you can't charge cost sharing for that service, which is great. But we still can see that in some of the other health plans, the standard Medicaid plans, et cetera. So those are two of the big ones that we really focus on.
Okay, wonderful. Let's just go through those questions for one more. Okay, I'm not seeing any other questions in the chat box. Oh, we just got one. Do you find that a lot of payers are applying the screening CT charges to the patient's deductible? You open that up to anyone.
They should not be.
Yeah.
If the patient is covered, they should not be charging it to the deductible because they should be getting, the payer should be getting paid in full from the carrier if the patient is eligible, right? So if they meet the screening criteria.
So that should be something that the patient or a patient navigator should follow up with the insurance company on if that is indeed the case.
Yes.
Okay, wonderful. Well, that looks like answers the last of our questions. And so I want to say on behalf of the Lung Association, another huge thanks to both Linda and to Claire for joining us today, to Hannah for all of her efforts on this, as well as our other colleague, Emma Will, who's been very involved in these data collection and efforts as well. And then, of course, to the MD Anderson Cancer Center for all of your support. So we thank you all. Again, this webinar will be available so that you can share the link or listen to it again within 24 hours. And if you do have any questions, you can contact the Lung Association team through lung.org/lung-cancer-coverage. And you can see all of our materials and then look to access and get a hold of us through there too. So thank you again and enjoy your afternoon.
That does conclude today's conference call. Thank you for participating.